Assalamu alaikum. So this is the second part of the lecture related to cerebral palsy. In this we are going to discuss how we are going to evaluate the condition and what its management. First come the evaluation. In the evaluation first we determine how the patient, what are the basically the past history of the patient. We are going to assess different risk factors of the CP, how what is basically the past history of the patient. So first, we have to consider and we have to memorize that the cerebral palsy cannot be diagnosed before the 6 months of the infant life. It can diagnosed after the 6 months. So, what we are going to assess, we ask the patient, we ask the parents about what are if there is a delay in the milestones of the patient. For example, milestones are basically the sitting, neck holding is the first milestone, then the sitting, crawling, standing, etc. So in patients suffering from the cerebral palsy, there is the lead in the achievement of these milestones. The second is the premature birth. If the patient, if the infant is delivered or if the infant is born before the 9 months of the pregnancy, then there is a chances that the patient is suffering from cerebral palsy. And we had discussed as we have discussed the different risk factors in different period of the life. If any one of these risk factors is present, then the patient can suffering from cerebral palsy. Fourth point which we are going to discuss in the history is that if any one of the family members is previously suffering from this condition, then there is a chances that the patient is suffering from cerebral palsy. Next comes the physical examination. So in physical examination, first we are going to see if there is a spasticity in the muscle. We are going to perform the range of motion at that joint at the particular ranges, like dorsiflexion, plantarflexion. These are restricted. And say second comes the reflexes. In the patient suffering from CP, there are exaggerated clonus, plantar responses, and the deep tendon reflexes. And in the third point comes the primitive reflexes. As we all know that the primitive reflexes are the reflexes that are going to disappear after a certain time period in the infant. For example, some of the primitive reflexes includes the motor reflex, asymmetric tonic neck reflex, labyrinthine reflex. But in the patient suffering from the cerebral palsy, these reflexes does not disappear after the 6 months of the time period. Means they are present in the infant after 6 months. So it is basically the major examination on the basis of which we are diagnosed that the patient is suffering from cerebral palsy. Next comes the medical management of the disease. First is the drug. What drugs we are going to give in to the patient suffering from CP. For example, diclofenac is a drug which are going to the patient in order to reduce their hypertonicity in the muscle. But if, as we have discussed in the clinical presentation, and that one of the presentation of the patient suffering from CP is epileptic disorders. Epileptic seizures can also occur in the patient. So if the person complains the epileptic seizure, then diclofenac is not given to the patient because it can exaggerate the condition either than to relieve it. The next is the surgical management. In surgical management, we have done tenotomy or myotomy. Tenotomy is basically the cutting of the tendon. If the tendon is cut, then the muscles tonicity is decreased, and myotomy is also the cutting of the muscle mass in order to reduce the hypertonicity. The next comes the physical therapy management. In physical therapy management, we are going to either stretch the muscles which are hypertonic. For example, our knee flexor contractures. If knee flexor contractures develop, then we are going to stretch the we are going to stretch the hamstring muscles. But stretching is gentle and sustained stretching is done. Sustained stretching means we are going to stretch the muscle for 10 to 15 seconds, but gentle stretching is done because there are the chances that if we done the aggressive stretching, then the muscle fibers can become torn. Also, there is the stretching of the gastrosoleus complex because the patient of the cerebral palsy represented the plantar flexion contractures. So it is because of the spasticity of the gastrosoleus complex and the tibialis posterior. So we are going to stretch these muscles and also the hip adductors muscle. The next come the strengthening exercises. So the muscles which are going to which have become hypertonic or spastic, their antagonists become weak. For example, if the gastrosoleus complex has become spastic, then the tibialis anterior muscle, which are going to perform the dorsiflexion at the ankle joint, become weakened. So we are going to perform the passive movement at these joints. So because of this, the muscles gain the strength, and active range of the motion also occur at that joint. The next come the balance exercises. As we have discussed in the eat exec CP, that the balance sitting and the standing balance is disturbed. So we are going to in the balance exercises, because we are going to strengthen the postural muscles and performing the balancing exercises. For example, in this picture we have seen that the patient is sitting on a gym ball, and this is basically the balance exercises for the sitting. Also for the neck holding and bridge, we have performed the paraspinal muscle strengthening, so that the patient is able to perform the neck holding. Next is a constraint induced movement therapy. We are going to define constraint induced movement therapy as we restrain the unaffected side of the body and encourage the children to perform the activity with their affected hand. Because of this, they are going to perform the activities with this hand, so the movement become smoothen, and their spasticity decrease, and the muscles which are going to become weakened become gains the strength. So this is basically a type of conditioning. The next is the neuromuscular electrical stimulation. Neuromuscular, because we are going to apply the electrodes on the muscle which have become weakened. For example, tibialis anterior muscle, we place 2 electrodes in it, and the small intensity current is supplied to that muscle, so that they become activated and perform the movement. The next comes the functional electrical stimulation. So how it is different from neuromuscular electrical stimulation is that in neuromuscular electrical stimulation, the current is provided for a smallest period of the time, and after that we perform the passive movement at that joint or of that muscle. But in functional electrical stimulation, when we apply the electrodes and provided the current, then when the current is provided to that muscle, the muscle become do the involuntary contraction, means they are going to dorsiflex the ankle involuntary. So this is the difference between functional electrical stimulation and neuromuscular electrical stimulation. In functional, movement occur involuntary during the electrical stimulation, and in neuromuscular electrical stimulation, we have to perform the movement after the electrical stimulation is done. The next come the use of orthotics. So why we are giving the orthotics to the patient? First, they have attained the balance. The first criteria, the first our goal is to maintain the balance, and the second one is to provide the continuous stress to the muscle. For example, if we have saw the ankle foot orthosis, they are going to place the position, they are going to place the ankle joint in the neutral position, not in the plantar flexion. So it produces sustained stretching on the plantar flexion, and prevent the development of the plantar flexor contractures. Thank you.